What infection control measures should be taken when using ventilators?
When utilizing ventilators, a multifaceted approach to infection control is paramount to safeguard patient well-being and prevent healthcare-associated infections. This begins with rigorous hand hygiene, ensuring that medical personnel thoroughly wash their hands with soap and water or use an alcohol-based hand rub both before and after any interaction with the patient or the ventilator circuit. Beyond this fundamental practice, strict adherence to aseptic technique during all procedures involving the ventilator is critical. This includes when connecting or disconnecting the patient from the circuit, performing suctioning, or handling respiratory secretions. All components of the ventilator circuit that come into contact with the patient, such as tubing, humidifiers, and filters, must be sterilized or high-level disinfected between patients, following established institutional protocols and manufacturer guidelines. Furthermore, regular surveillance and cleaning of the ventilator equipment and surrounding environment are essential. This involves wiping down external surfaces with appropriate disinfectants and ensuring the immediate patient care area is consistently clean. Moreover, patient-specific measures are equally important, encompassing proper oral care to reduce bacterial load in the oral cavity, judicious use of sedatives to facilitate spontaneous breathing trials and minimize ventilator days, and elevation of the head of the bed to prevent aspiration. Finally, ongoing education and competency assessments for all staff involved in ventilator care are crucial to ensure consistent application of these infection control measures.
What are the key settings to monitor on a ventilator, and how do they affect patient outcomes?
Monitoring key settings on a ventilator is crucial for ensuring optimal respiratory support and preventing complications, ultimately having a significant impact on patient outcomes. One of the primary settings to diligently observe is tidal volume, VT, which dictates the amount of air delivered with each breath. Maintaining an appropriate tidal volume, typically guided by ideal body weight, is essential to prevent both volatrauma, injury from overstretching the alveoli, and atelectrauma, injury from repeated collapse and reopening of lung units. Deviations from the optimal range can lead to lung injury and prolonged ventilation, thus worsening patient prognosis. Another critical setting is respiratory rate, RR, or the number of breaths the ventilator provides per minute. Adjusting the respiratory rate in conjunction with tidal volume influences the patient's minute ventilation, which directly impacts carbon dioxide elimination. An inadequate rate can lead to hypercapnia, causing respiratory acidosis, while an excessively high rate can induce autopeep and contribute to air trapping. Careful titration of this setting helps maintain acid-base balance and minimizes the work of breathing for the patient. Positive end expiratory pressure, PEEP, is also a vital parameter, as it applies continuous positive pressure at the end of exhalation to prevent alveolar collapse and improve oxygenation. Appropriate PEEP levels can recruit collapsed lung units and reduce the work of breathing, enhancing oxygen delivery to tissues. Conversely, too much PEEP can impede venous return, leading to hypotension and decreased cardiac output, while insufficient PEEP may result in hypoxemia and lung injury. Therefore, finding the right PEEP for each patient is a delicate balance to optimize oxygenation while minimizing adverse cardiovascular effects. Furthermore, fraction of inspired oxygen, VO2, is meticulously monitored to deliver the lowest possible oxygen concentration required to maintain adequate oxygen saturation. While essential for oxygenation, prolonged exposure to high VO2 can lead to oxygen toxicity and lung damage. Nurses must constantly assess the patient's oxygenation status through pulse oximetry and arterial blood gas analysis to titrate VO2 down as quickly as clinically appropriate. Finally, peak inspiratory pressure, PIP, and plateau pressure, PLAT, provide valuable insights into lung mechanics. PIP reflects the maximum pressure during inspiration and is influenced by airway resistance and lung compliance. PLAT, measured during an inspiratory hold, reflects alveolar pressure and is a better indicator of lung compliance. Keeping plateau pressures below 30 cmH2O is a standard protective lung strategy to prevent barotrauma, which can cause pneumothorax or other forms of ventilator-induced lung injury. Continuous monitoring and adjustment of these settings alongside vigilant patient assessment are fundamental to safe and effective mechanical ventilation and directly correlate with improved patient recovery, reduced complications, and ultimately better outcomes.
Explain the functioning of PEP, positive end expiratory pressure, and its importance in ventilator management.
Positive end expiratory pressure, or PEP, is a fundamental setting in mechanical ventilation that applies continuous positive pressure to the airways at the end of exhalation. Unlike spontaneous breathing, where pressure in the lungs typically returns to atmospheric levels during expiration, PEP ensures that a certain amount of pressure is maintained, preventing the alveoli, the tiny air sacs in the lungs where gas exchange occurs, from completely collapsing. The primary function of PEP is to recruit collapsed alveoli and keep them open. In many respiratory conditions such as acute respiratory distress syndrome, ARDS, or pneumonia, alveoli can collapse, leading to atelectasis, which significantly reduces the surface area available for oxygen to diffuse into the bloodstream. By maintaining a positive pressure, PEP helps to splint these fragile alveoli open, thereby increasing the functional residual capacity of the lungs and improving gas exchange. This recruitment of otherwise collapsed lung units directly enhances oxygenation and can reduce the need for dangerously high concentrations of inspired oxygen, FiO2, mitigating the risk of oxygen toxicity. The importance of PEP in ventilator management is multifaceted. Firstly, by preventing the cyclic collapse and reopening of alveoli, PEP minimizes what is known as atelectrauma, a form of ventilator-induced lung injury. This repeated mechanical stress can cause inflammation and further lung damage. Secondly, by improving oxygenation, PEP reduces the patient's work of breathing and alleviates hypoxemia, which can decrease the physiological stress on the body and potentially lead to earlier weaning from mechanical ventilation. However, nurses must vigilantly monitor PEP levels, as inappropriately high PEP can have adverse effects. Excessive intrathoracic pressure can impede venous return to the heart, leading to reduced cardiac output and hypotension, which can compromise organ perfusion. It can also increase the risk of barotrauma, such as pneumothorax, by overdistending already healthy lung tissue. Therefore, titrating PEP to the optimal level is a delicate balance, aiming to maximize alveolar recruitment and oxygenation benefits while minimizing potential hemodynamic compromise and lung injury. This precise management, guided by careful patient assessment and monitoring of oxygen saturation and blood pressure, is crucial for optimizing patient outcomes and supporting their recovery.
How would you calibrate a ventilator? What steps are involved in ensuring accuracy?
Calibrating a ventilator is a critical pre-use procedure, typically performed by a respiratory therapist or a specifically trained biomedical engineer, although nurses play a vital role in verifying its operational readiness and understanding the implications for patient safety. While nurses generally do not perform the intricate internal calibration of the ventilator's sensors and circuits, we are responsible for conducting essential pre-use checks and circuit integrity tests to ensure the machine is functioning accurately and safely before connecting it to a patient. The steps involved in ensuring accuracy begin with a thorough visual inspection of the entire ventilator unit. This includes checking the power cord for damage, ensuring all connections are secure, and verifying the integrity of the breathing circuit, the tubing, humidifier, and filters for any visible defects or contaminants. Any cracks, kinks, or disconnections in the circuit can lead to significant volume leaks, compromising ventilation efficiency and patient safety. Following the visual inspection, a crucial step is performing a leak test of the ventilator circuit. This is a standard procedure that assesses the airtightness of the entire system, from the ventilator outlet to the patient connection point. The ventilator's internal self-test function is typically initiated, which pressurizes the circuit to a specific level and then monitors for any pressure drop over a set period. A significant drop indicates a leak, which must be identified and rectified before use. This ensures that the delivered tidal volume and pressure settings will actually reach the patient's lungs without loss. Beyond the circuit integrity, nurses also verify the functionality of all alarms by simulating various alarm conditions, such as high pressure, low pressure, or apnea. This confirms that the alarms are audible, visible, and activate appropriately when specific parameters are exceeded or compromised. Accurate alarms are our primary safety net, alerting us to critical changes in patient status or ventilator malfunction. Finally, nurses confirm that the ventilator settings align precisely with the physician's orders for the patient. This involves meticulously checking the mode of ventilation, tidal volume, respiratory rate, FiO2, PEP, and any other prescribed parameters. This cross-verification ensures that the machine is set to deliver the intended therapeutic support. While the deep technical calibration is for specialized personnel, the nurse's diligent pre-use checks and ongoing monitoring are indispensable in guaranteeing the continuous accuracy and safe delivery of mechanical ventilation.
What safety protocols are necessary when using and maintaining ventilators?
Ensuring patient safety when using and maintaining ventilators is paramount and involves a combination of meticulous protocols, continuous monitoring, and effective interdisciplinary collaboration. At the core, it begins with strict adherence to pre-use checks before initiating ventilation for any patient. This involves verifying the ventilator's functionality, ensuring all alarms are active and set appropriately, confirming the integrity of the breathing circuit for any leaks or disconnections, and checking that the emergency manual resuscitator bag valve mask, BVM, is readily available and functional at the bedside. These initial steps are crucial for preventing immediate patient harm due to equipment malfunction. During ongoing use, constant patient assessment and vigilant monitoring of both the patient and the ventilator are indispensable. This includes frequently assessing the patient's respiratory status, comfort level, and vital signs, alongside continuous monitoring of ventilator waveforms and alarm settings. Nurses must be proficient in recognizing and responding to various alarms, understanding whether a high-pressure alarm indicates a kinked tube or a patient coughing, or if a low-pressure alarm signals a disconnection. Prompt identification and resolution of these issues are critical to maintaining adequate ventilation and preventing adverse events. A significant safety protocol centers around infection prevention, particularly to mitigate the risk of ventilator-associated pneumonia, VAP. This involves elevating the head of the bed to 30 to 45 degrees unless contraindicated, performing meticulous oral care with appropriate antiseptic solutions to reduce bacterial load, and implementing daily sedation vacations to assess the patient's readiness for extubation. Minimizing ventilator days is a key strategy for reducing VAP risk, highlighting the importance of collaborative weaning protocols. Maintaining strict hand hygiene before and after any contact with the patient or ventilator circuit, along with a septic technique during suctioning and circuit changes, are also fundamental in preventing infections. Furthermore, securing the artificial airway endotracheal or tracheostomy tube meticulously is vital to prevent accidental extubation, which can be life-threatening. This involves routinely checking the tube's position, e.g., at the lip line in centimeters, and ensuring the securement device, tape or commercial holder, is intact and properly applied. Skin integrity around the tube insertion site also needs constant assessment to prevent pressure injuries. For maintenance, it is crucial that routine preventive maintenance (PM) checks are performed by qualified biomedical technicians according to manufacturer guidelines and hospital policy. Nurses should be aware of when these checks are due and report any perceived equipment malfunctions promptly. Between patients, thorough cleaning and high-level disinfection or sterilization of reusable ventilator components are mandatory to prevent cross-contamination. Single-use components are appropriately discarded. Finally, effective interdisciplinary communication and standardized protocols are overarching safety measures. This means clear communication between nurses, respiratory therapists, and physicians regarding ventilator settings, patient status, and any changes in the care plan. Adhering to established unit and hospital policies for ventilator management, including weaning protocols, ensures a consistent and safe approach to care. These combined efforts create a robust safety net for patients requiring mechanical ventilation.
How would you troubleshoot a ventilator that has suddenly stopped working during a procedure?
When a ventilator suddenly stops working during a procedure, it's a critical emergency requiring immediate, decisive action to ensure patient safety. My approach would follow a systematic ABC airway, breathing, circulation framework to troubleshoot the issue quickly and effectively. The absolute first step is to prioritize the patient's immediate ventilation. This means disconnecting the patient from the malfunctioning ventilator and manually ventilating them with a bag valve mask, BVM, connected to 100% oxygen. This ensures continuous oxygenation and ventilation while the problem is being identified. Simultaneously, I would immediately call for help, alerting the respiratory therapist, charge nurse, and physician to the situation. Once the patient is safely ventilated manually, I would begin rapid troubleshooting of the ventilator itself. This involves checking the most common and easily rectifiable issues. First, I would verify the power source. Is the ventilator plugged in? Is the power cord secure? Has a circuit breaker tripped? Sometimes, a simple disconnection can cause the cessation of function. Next, I would inspect the gas supply. Is the oxygen tank or wall oxygen source connected and turned on? Is there adequate pressure? A depleted or disconnected gas supply can cause the ventilator to cease operation. Concurrently, I would perform a quick visual inspection of the entire ventilator circuit, looking for any obvious disconnections, kinks in the tubing, or damaged components. A complete circuit break, even a subtle one, can lead to the ventilator stopping or alarming excessively. I would also quickly check the patient's artificial airway, endotracheal or tracheostomy tube, for any signs of dislodgement or obstruction, as an issue with the airway itself can mimic a ventilator malfunction. While manually bagging the patient, I would also pay close attention to the feel of the bagger's resistance and the patient's chest rise. This provides immediate feedback on lung compliance and airway patency, helping to differentiate between a ventilator problem and a patient-related issue like a pneumothorax or a major airway obstruction. If the bag is very stiff to compress, it suggests a high-resistance problem within the patient or airway. If these initial rapid checks do not resolve the issue, and with manual ventilation ensuring patient stability, the next step would be to switch to a backup ventilator if one is immediately available. This allows for continuation of mechanical ventilation with minimal interruption, while the primary unit can be thoroughly assessed by biomedical engineers. Documentation of the event, including all observations and actions taken, is crucial once the immediate crisis is averted. The overall goal is always to maintain effective ventilation and oxygenation for the patient, using manual bagging as the bridge until the ventilator problem is resolved or a replacement is secured.
What are the different types of ventilators, and how do their functionalities vary?
There are several types of ventilators used in clinical settings, and their functionalities vary depending on the patient's condition and the level of respiratory support required. The most common categories include volume-cycled, pressure-cycled, time-cycled, and flow-cycled ventilators. Volume-cycled ventilators deliver a preset tidal volume to the patient with each breath, regardless of the pressure required to achieve it. This type is often used when ensuring consistent lung expansion is critical, such as in post-operative patients or those with stable lung compliance. In contrast, pressure-cycled ventilators deliver air until a preset pressure is reached, making them suitable for patients with fragile lung structures where avoiding barotrauma is a priority. However, the tidal volume in pressure-cycled modes can vary depending on lung resistance and compliance. Time-cycled ventilators, commonly used in neonatal or pediatric care, terminate inspiration after a set time interval, which allows for very controlled and gentle ventilation in delicate lungs. Flow-cycled ventilators, often seen in non-invasive ventilation such as BiPAP or CPAP, in the inspiratory phase when inspiratory flow drops below a certain threshold. These are particularly beneficial for patients with conditions like COPD or sleep apnea, because they better accommodate spontaneous breathing patterns. Each ventilator type can be used in different modes, such as assist control, synchronized intermittent mandatory ventilation (SIMV), or pressure support, which further tailor the ventilation to the patient's respiratory effort and condition. As nurses, it's essential to understand not just the mechanical functions but also the physiological implications of each ventilator type so we can monitor effectively, prevent complications, and collaborate with respiratory therapists and physicians to adjust settings based on the patient's evolving needs.
What data metrics are crucial to monitor on a ventilator, and why are they significant?
When caring for a patient on a ventilator, meticulous monitoring of specific data metrics is absolutely crucial, as these provide real-time insights into lung mechanics, gas exchange efficiency, and the overall effectiveness of mechanical ventilation, directly influencing patient management and outcomes. One of the most fundamental metrics is tidal volume, VT, representing the volume of air delivered with each breath. Its significance lies in ensuring adequate ventilation while preventing lung injury. Too low a tidal volume can lead to hypoventilation and hypercapnia, meaning insufficient carbon dioxide removal. Conversely, an excessively high tidal volume can cause volatrauma, leading to alveolar overdistension and damage. Monitoring VT ensures we deliver just enough air to meet metabolic needs without harming the delicate lung tissue. Equally vital is the respiratory rate, R, or breaths per minute. Combined with tidal volume, it determines the minute ventilation, MV, which is the total volume of air moved in and out of the lungs per minute. MV is paramount for carbon dioxide homeostasis. Deviations in RR or MV, particularly unexpected increases, can signal increased work of breathing, worsening lung compliance, or an emerging metabolic acidosis requiring compensation. Maintaining an appropriate MV helps prevent dangerous acid-base imbalances. Peak inspiratory pressure, PIP, and plateau pressure are critical for assessing lung mechanics and avoiding barotrauma. PIP reflects the maximum pressure generated during inspiration and is influenced by airway resistance, e.g., bronchospasm, secretions, and lung compliance. Plateau pressure, measured during an inspiratory hold, brief cessation of airflow, reflects the actual pressure at the alveolar level and is a more accurate indicator of lung compliance. Keeping plateau pressure below 30 cm H2O is a standard protective lung strategy to minimize the risk of pressure-induced lung injury, such as pneumothorax. A rising PIP with a stable plateau pressure suggests increased airway resistance, while an increase in both indicates decreasing lung compliance. Positive end-expiratory pressure, PEP levels are also continuously monitored. PEP maintains positive pressure at the end of exhalation to prevent alveolar collapse, improve oxygenation by increasing functional residual capacity, and reduce atolect trauma. Its significance lies in optimizing oxygen delivery while minimizing lung injury. However, vigilance is required as excessive PEP can compromise hemodynamic stability by reducing venous return to the heart, leading to hypotension. Finally, fraction of inspired oxygen, FiO2, is a critical metric that quantifies the percentage of oxygen delivered to the patient. It is crucial to use the lowest possible FiO2 that achieves adequate oxygen saturation, SpO2, to prevent oxygen toxicity, which can damage lung tissue over prolonged exposure. Titrating FiO2 based on SpO2 and arterial blood gas, ABG, results as an ongoing process aimed at balancing oxygenation needs with the risk of oxygen-induced lung injury. Collectively, these metrics provide a holistic view of the patient's respiratory status, lung mechanics, and the ventilator's performance. Continuous monitoring and interpretation of these data points enable nurses to promptly identify subtle changes in the patient's condition, troubleshoot potential ventilator issues, adjust settings collaboratively with the medical team, and ultimately contribute significantly to positive patient outcomes, minimizing ventilator-associated complications.
How does the ventilatory mode impact oxygen delivery to patients?
The ventilatory mode significantly impacts oxygen delivery to patients by influencing how breaths are delivered, how much the patient participates in breathing, and ultimately, how efficiently gas exchange occurs in the lungs. Different modes achieve oxygenation in varying ways, primarily by affecting alveolar recruitment, ventilation perfusion matching, and the overall work of breathing. In volume control, VC modes, the ventilator delivers a set tidal volume with each breath, regardless of the pressure required. The primary way this impacts oxygen delivery is by guaranteeing a specific volume of gas reaches the alveoli. This predictability in volume can be advantageous for maintaining adequate minute ventilation and thus CO2 removal, but can also lead to higher peak inspiratory pressures if lung compliance worsens, potentially causing barotrauma or volatrauma, which can impair oxygenation by injuring lung tissue. While FiO2 and PEP remain direct determinants of oxygen delivery in this mode, the consistent volume ensures that sufficient fresh oxygen is presented to the gas exchange surface. In contrast, pressure control, PC modes deliver a set inspiratory pressure, allowing the tidal volume to vary based on the patient's lung compliance and airway resistance. This mode often results in a decelerating flow pattern, which can improve oxygenation by providing better distribution of gas to different lung units, especially those with varying compliance. By limiting peak airway pressure, PC modes inherently offer a degree of lung protection against barotrauma, which can indirectly enhance oxygen delivery by preserving lung integrity. However, the variable tidal volume means that if lung compliance deteriorates, the delivered volume might decrease, potentially leading to hypoventilation and impaired oxygenation if not carefully monitored. The emphasis here is on ensuring that the set pressure maintains sufficient alveolar recruitment and gas exchange. Synchronized intermittent mandatory ventilation, SIMV, allows for a combination of mandatory, synchronized breaths delivered by the ventilator and spontaneous breaths initiated by the patient. This mode impacts oxygen delivery by facilitating patient participation, which can reduce the need for heavy sedation and improve patient-ventilator synchrony. When the patient takes spontaneous breaths, they generate negative intrathoracic pressure, which can improve venous return and cardiac output, thereby enhancing systemic oxygen delivery perfusion. SIMV aims to balance ventilator support with a patient's own respiratory effort, which can be beneficial for weaning. However, if the spontaneous breaths are shallow or inadequate, it might compromise overall minute ventilation and thus oxygenation if not properly managed with pressure support. Assist control AC modes, whether volume or pressure, provide a mandatory breath every time the patient makes an inspiratory effort or if a set time interval elapses. This mode ensures that every patient-initiated breath receives full support, providing consistent tidal volumes, in AC volume, or pressures in AC pressure. This full support reduces the work of breathing, allowing the patient to rest and recover, which indirectly improves oxygen delivery by reducing metabolic demands and improving overall physiological stability. By guaranteeing consistent ventilation, AC modes effectively maintain CO2 removal and ensure a continuous supply of oxygen to the alveoli, preventing hypoxemia. Regardless of the mode, the fraction of inspired oxygen, FiO2, and positive end expiratory pressure, PEEP, are the most direct and universally applied settings for influencing oxygen delivery. FiO2 determines the concentration of oxygen in the gas mixture delivered to the patient, directly impacting the partial pressure of oxygen in the alveoli. PEEP helps to keep alveoli open at the end of exhalation, preventing collapse and increasing the surface area for gas exchange, thereby improving oxygenation and reducing shunt. In essence, while FiO2 and PEEP are the direct levers for oxygen delivery, the chosen ventilatory mode creates the mechanical environment that optimizes or can hinder the effectiveness of these settings. The best mode is one that allows for sufficient oxygenation and ventilation while minimizing ventilator-induced lung injury and promoting patient comfort and synchrony.
How do you evaluate the performance of a ventilator in a clinical setting?
Evaluating the performance of a ventilator in a clinical setting involves a combination of patient assessment, ventilator parameter monitoring, and interpretation of diagnostic data. The primary goal is to ensure that the ventilator is delivering adequate oxygenation and ventilation while minimizing patient discomfort and avoiding complications such as barotrauma or volatrauma. First, I closely monitor the patient's vital signs, particularly respiratory rate, oxygen saturation, SpO2, heart rate, and blood pressure, as these provide immediate feedback on how well the ventilator is supporting the patient. If there's increased work of breathing, agitation, or changes in consciousness, it may indicate inadequate ventilatory support or patient-ventilator dysynchrony. Second, I assess ventilator settings and readings such as tidal volume, peak inspiratory pressure, PIP, plateau pressure, respiratory rate, minute ventilation, and FiO2. I also look at alarms triggered on the ventilator, which might indicate issues like high pressure, low tidal volume, or disconnection. These alerts need to be investigated promptly to ensure safe operation. Third, arterial blood gas ABG analysis plays a crucial role. It helps evaluate whether the patient is being properly ventilated via PaCO2 levels and oxygenated via PaO2 and SaO2. A mismatch between clinical signs and ABG values may signal that adjustments to the ventilator settings are necessary. Additionally, I consider lung compliance and resistance trends. Changes in these values can suggest evolving pathologies such as fluid overload, bronchospasm, or worsening ARDS. If the patient is on modes that allow spontaneous breathing, I assess their comfort, synchrony, and readiness for weaning. In collaboration with respiratory therapists and physicians, I use all these data points to evaluate not only whether the ventilator is functioning mechanically, but whether it is effectively supporting the patient's clinical needs.
What parameters do you assess to determine if a patient is ready to wean off a ventilator?
Determining a patient's readiness to wean off a ventilator is a systematic and multidisciplinary assessment that focuses on several key parameters, ensuring both respiratory and overall physiological stability before attempting liberation from mechanical support. My assessment would encompass a comprehensive review of the patient's underlying condition, respiratory mechanics, gas exchange, and hemodynamic status. Firstly, I would assess the resolution or significant improvement of the underlying condition that necessitated mechanical ventilation. For instance, if the patient was intubated for severe pneumonia, I would look for clear signs of infection resolution, such as decreasing white blood cell count, stable temperature, improving chest X-ray findings, and reduced sputum production. Weaning attempts are unlikely to be successful if the primary respiratory insult is still active. Secondly, a crucial component involves evaluating respiratory mechanics and effort. I would observe the patient's spontaneous breathing effort, noting their respiratory rate, tidal volume, and pattern. Key objective parameters include the Rapid Shallow Breathing Index, RSBI, calculated as respiratory rate divided by tidal volume in liters. An RSBI, typically below 105, suggests a higher likelihood of successful weaning. I would also assess negative inspiratory force, NIF, or maximum inspiratory pressure, MIP, which measures the patient's inspiratory muscle strength. A strong NIF, generally less than -20 to -30 centimeters H2O, indicates adequate inspiratory muscle strength to sustain spontaneous breathing. The patient's ability to tolerate a spontaneous breathing trial, SBT, typically for 30 to 120 minutes on minimal support, example, CPAP with 5 centimeters H2O PEEP and 5 to 7 centimeters H2O pressure support, is perhaps the most reliable predictor of weaning success. During this trial, I would monitor for signs of distress like tachypnea, tachycardia, increasing SpO2 requirements, or paradoxical breathing. Thirdly, gas exchange parameters are critically important. I would review recent arterial blood gas ABG results to ensure adequate oxygenation with a low fraction of inspired oxygen, FiO2, typically less than or equal to 0.40 to 0.50, and acceptable positive end-expiratory pressure, PEP levels, usually 5 to 8 centimeters H2O. The PaO2/FiO2 ratio should ideally be greater than 200 to 300 millimeters of mercury. Maintaining a stable PaCO2 and pH within normal limits also indicates effective ventilation without mechanical support. Fourthly, I would assess the patient's hemodynamic stability. This means ensuring a stable heart rate, blood pressure, and absence of escalating vasopressor support. Patients who are hemodynamically unstable or require significant cardiovascular support are typically not good candidates for weaning, as the increased work of breathing can place undue stress on the cardiovascular system. Finally, other crucial factors include the patient's neurological status. They should be awake, alert, and able to protect their airway with a strong cough and gag reflex. Their nutritional status should be optimized, as malnutrition can impair respiratory muscle strength. Their fluid balance should also be well managed, as fluid overload can worsen lung compliance. Collaboration with the physician and respiratory therapist is ongoing throughout this assessment, ensuring all criteria are met before attempting liberation from the ventilator. The decision to wean is a complex one, balancing the benefits of extubation with the risks of reintubation.
Can you give an example of a time when you faced a significant challenge with a ventilator device? What steps did you take to resolve it?
During my time working in the intensive care unit, I encountered a significant challenge with a ventilator device that required swift and systematic intervention. We had a patient, Mr. Smith, who was recovering from pneumonia and was on a volume-controlled ventilation mode. One evening, the ventilator suddenly began alarming persistently for high peak inspiratory pressure, and I immediately noticed Mr. Smith's SpO2 starting to trend downwards, and his breathing became more labored. My first and immediate step was to prioritize the patient's safety. I quickly assessed Mr. Smith, confirmed his worsening respiratory effort, and without hesitation, I disconnected him from the ventilator and initiated manual ventilation using a bag valve mask, BVM, connected to 100% oxygen. Simultaneously, I called for assistance from the respiratory therapist and the charge nurse, clearly stating the emergent situation. While manually ventilating Mr. Smith, I began my rapid, systematic troubleshooting of the ventilator and the patient. I performed a quick visual inspection of the entire circuit, checking for any visible kinks in the tubing, disconnected segments, or excessive secretions in a humidifier. I also quickly assessed the endotracheal tube itself for any signs of displacement or obstruction, though his chest rise with the BVM was symmetrical, suggesting the tube was in place. The resistance I felt while bagging was high, indicating an issue within the patient's airway or lungs rather than a simple circuit leak. Given the high pressure and increasing difficulty bagging, my immediate thought was a potential bronchospasm or increased secretions. I promptly suctioned Mr. Smith's airway, and while a small amount of tenacious sputum was retrieved, it didn't fully resolve the high resistance. Recognizing the patient's worsening condition and the persistent high pressure, I then considered a pneumothorax as a possibility, though there were no immediate unilateral breath sound changes. The respiratory therapist arrived quickly, and after a brief report, we jointly assessed Mr. Smith. The therapist confirmed a high resistance upon bagging. We then collaboratively tried a rapid change of the ventilator circuit, as a very subtle internal issue with the circuit could still be a factor despite visual inspection. However, even with the new circuit, the ventilator continued to alarm on the test run, indicating the problem was indeed with the machine itself or a severe patient issue. Since the ventilator's internal test was failing and manual bagging was proving increasingly difficult, we collectively decided to switch Mr. Smith to a spare, fully checked backup ventilator that was immediately available in the unit. After connecting him to the new ventilator, the high-pressure alarm ceased, and his SpO2 began to recover. We then meticulously set the parameters on the new ventilator according to his previous settings and his improving clinical status. The original ventilator was immediately tagged for biomedical engineering review, ensuring it would not be used again until thoroughly inspected and repaired. This experience reinforced the critical importance of a systematic approach to troubleshooting, prioritizing patient safety through manual ventilation, and the invaluable role of interdisciplinary teamwork in managing ventilator emergencies.
Discuss a time when you had to make a quick decision regarding a patient's ventilation needs. What factors did you consider?
During my time in the ICU, I had a patient with severe pneumonia on mechanical ventilation. Around 2 a.m. during night rounds, I noticed a sudden drop in the patient's oxygen saturation from 96% to 84%, accompanied by labored breathing despite being on assist control mode. Alarms were triggered for high peak inspiratory pressure, and the ventilator waveform showed signs of increased airway resistance. At that moment, I had to act quickly. My immediate priority was to assess whether the issue was equipment-related or patient-related. I checked the endotracheal tube for kinking or displacement, suction for potential mucus plugging, and simultaneously requested a stat ABG and alerted the on-call physician. While troubleshooting, I manually ventilated the patient using a bag valve mask to stabilize oxygenation. Auscultation revealed decreased breath sounds on the right, raising suspicion of a possible pneumothorax or mucus obstruction. I also reviewed the latest chest X-ray, which had shown some consolidation but no signs of collapse earlier in the shift. The key factors I considered were oxygen saturation trends, ventilator pressures, breath sounds, patient comfort, and the time-sensitive need to maintain adequate ventilation while identifying the root cause. We later confirmed the issue was due to a thick mucus plug causing partial obstruction. After effective suctioning and temporary adjustment of ventilator settings, raising the inspiratory time and pressure support, the patient's oxygenation improved and they stabilized. That situation underscored the importance of critical thinking under pressure, rapid assessment skills, and knowing when to escalate. It also reinforced the need for constant vigilance with ventilated patients, even when they appear stable.
Tell me about how you prioritize your tasks when managing multiple patients on ventilators.
When managing multiple patients on ventilators, I prioritize tasks based on clinical urgency, airway security, and the stability of each patient. My first step is always to assess for any immediate threats to life. This includes checking for high-priority ventilator alarms, sudden desaturations, or signs of patient ventilator dyssynchrony. Any patient showing acute changes in vital signs or ventilator parameters gets my attention first. After addressing any critical issues, I shift to a systematic review of each ventilated patient. I assess vital signs, ventilator settings, waveforms, and ensure that sedation or analgesia is appropriately titrated. I check ABG results, if pending, and correlate them with the clinical picture. I also ensure suctioning is performed as needed and check for tube patency and positioning. To stay organized, I use a task list with time-sensitive interventions clearly marked, such as medication schedules, spontaneous breathing trials, or ventilator weaning readiness assessments. I also communicate continuously with the respiratory therapist and the medical team to coordinate care and anticipate changes in patient status or treatment plans. For less acute tasks, like documentation or equipment checks, I batch them efficiently once the high-priority items are stabilized. Throughout my shift, I remain flexible, knowing that ventilated patients can deteriorate quickly, so I constantly reassess and reprioritize as needed. Ultimately, my goal is to provide safe, responsive care to each patient while keeping a calm, methodical approach under pressure.
How do you manage stress during emergencies involving ventilator-dependent patients?
In emergencies involving ventilator-dependent patients, managing stress starts with controlling my response to the situation. I rely on training, routine, and critical thinking to stay calm and focused. The first thing I do is take a mental pause, even if it's just a second, to center myself. That helps me avoid reacting impulsively and instead approach the emergency with clarity. My immediate focus is always patient safety. I follow the ABC approach, airway, breathing, circulation, which helps me structure my assessment even under pressure. For example, if there's a sudden drop in oxygen saturation or the ventilator alarms go off, I methodically check the circuit, the patient, and the machine while calling for backup or alerting the medical team as needed. Delegation is also key. I involve other nurses, respiratory therapists, or junior staff to ensure tasks like manual ventilation, suctioning, or medication prep happen simultaneously. What helps me manage the emotional side of stress is preparation. I make it a point to stay updated on emergency protocols and ventilator troubleshooting, so when something happens, muscle memory takes over. After the emergency is resolved, I take time to reflect on what went well and what could be improved. I also talk to colleagues. I find that debriefing, even informally, helps process the stress and reinforces team support. In short, I manage stress during ventilator-related emergencies by staying clinically grounded, following protocols, communicating clearly, and keeping my focus where it matters most, on the patient's immediate needs.
How do you keep yourself updated with the latest developments in ventilator technology?
To stay updated with the latest developments in ventilator technology, I take a proactive, multi-source approach. I regularly participate in continuing professional development (CPD) activities, including workshops and in-service training sessions, especially those led by respiratory therapists or equipment specialists. These sessions often introduce new models, modes, and safety features in ventilators that are being integrated into clinical practice. I also subscribe to reputable nursing and critical care journals such as American Journal of Critical Care and Nursing Times, which often publish peer-reviewed articles on advances in ventilator strategies, weaning protocols, and patient ventilator synchrony. When new studies or guidelines come out, like updates from the ARDS-NET protocol or recommendations from the European Society of Intensive Care Medicine, I review them and reflect on how they apply to our local context. In addition, I stay connected with my professional network. I regularly consult with respiratory therapists, ICU consultants, and colleagues during case discussions or interdisciplinary rounds, which often bring up real-world insights into evolving practices. I also engage in online learning platforms and webinars, especially those offered by ventilator manufacturers, which provide hands-on tutorials and updates on advanced features such as closed-loop systems and adaptive support ventilation. Ultimately, I believe staying current is part of my responsibility, not just to operate the equipment effectively, but to ensure patients receive the safest, most evidence-based care possible.
Imagine a scenario where a patient's oxygen saturation is dropping rapidly despite being on a ventilator. What immediate actions would you take?
If a patient's oxygen saturation is dropping rapidly while on a ventilator, my immediate focus is to stabilize the patient and identify the cause. The first thing I do is quickly assess the patient visually and clinically. Are they in distress? Is the chest rising symmetrically? Is there cyanosis or increased accessory muscle use? Next, I check the ventilator and circuit connections. A loose or disconnected circuit, a kinked endotracheal tube, or an accidental extubation can cause sudden desaturation. I listen for breath sounds on both sides. Diminished or absent sounds could indicate a pneumothorax or tube misplacement into one bronchus. If I can't quickly correct the issue and the patient continues to deteriorate, I will immediately disconnect the ventilator and begin manual ventilation with a bag valve mask, ambu bag, ensuring I'm delivering high-flow oxygen and achieving chest rise. At the same time, I will call for urgent medical review and alert the respiratory therapist and the ICU team. While ventilating manually, I reassess. I check for airway obstruction due to secretions, in which case I perform suctioning. I also verify the most recent ventilator settings and alarms. High peak pressures or low tidal volumes can give clues. If pneumothorax is suspected, I prepare for emergency chest decompression and assist the medical team as needed. Throughout the process, I ensure that vital signs are monitored continuously and document the sequence of events and interventions clearly. The priority is always the ABC approach: airway, breathing, circulation, and staying composed so I can lead the response effectively and safely.
How would you explain the necessity and functionality of a ventilator to a patient or their family?
When explaining the necessity and functionality of a ventilator to a patient or their family, I focus on being honest, calm, and using simple, non-technical language. I begin by reassuring them that our goal is to support the patient's breathing while we treat the underlying issue. I might say something like, "Right now, your loved one's lungs are not able to get enough oxygen into the body or remove carbon dioxide effectively on their own. The ventilator is a machine that helps them breathe while their body recovers." I explain that the ventilator pushes air, often with extra oxygen, into the lungs through a breathing tube placed in the windpipe. Depending on the situation, the machine can either do all the breathing for the patient or assist them when they take a breath on their own. I make sure to address concerns about discomfort, sedation, and the fact that the patient may not be able to speak while intubated. I also explain that being on a ventilator doesn't mean the situation is hopeless. It's a form of life support that gives the body a chance to heal. If the family seems overwhelmed, I pause often, invite questions, and repeat key information as needed. I also explain that we monitor everything closely: oxygen levels, pressure in the lungs, and the patient's comfort to make sure the ventilator is doing its job safely and effectively. Ultimately, my goal is to help the family feel informed and supported without sugarcoating the seriousness of the situation, so they can process what's happening and trust that their loved one is receiving appropriate care.
What would you do if you notice that a patient is not responding as expected to the ventilator settings?
If I notice that a patient is not responding as expected to the ventilator settings, my first step is to conduct a quick but thorough assessment of both the patient and the ventilator. I'll look for signs of respiratory distress, changes in consciousness, accessory muscle use, or abnormal chest rise. I also check the ventilator waveforms, settings, and recent alarm history to identify any technical issues or mismatches between the machine and the patient's respiratory effort. Next, I verify airway patency. This includes checking for kinks or disconnections in the tubing, dislodgement of the endotracheal tube, or obstruction due to secretions. I listen for bilateral breath sounds and perform suctioning if necessary. If breath sounds are diminished or asymmetric, I consider complications like pneumothorax or atelectasis and escalate immediately. I also review recent arterial blood gas (ABG) results and compare them to current settings and clinical signs. For example, a rising PaCO2 despite high respiratory rate could signal hypoventilation or ventilator patient asynchrony. I then collaborate with the respiratory therapist and the physician to reassess ventilator mode, tidal volume, PEP, and FiO2, and adjust settings as needed. Throughout, I ensure the patient remains stable, manually ventilating with an ambu bag if oxygenation drops significantly, and I escalate the situation promptly if I can't resolve it quickly. I document the issue, actions taken, and the patient's response in detail. Ultimately, it's about staying alert, responding systematically, and using teamwork to troubleshoot and stabilize the patient without delay.
How would you collaborate with other healthcare professionals to manage a ventilated patient?
Managing a ventilated patient effectively requires a multidisciplinary approach, where clear communication and collaboration among healthcare professionals are essential to ensure patient safety and optimal outcomes. As a nurse, my role involves coordinating closely with a respiratory therapist, physician, and critical care team to assess, monitor, and adjust ventilation strategies based on the patient's condition. First, I would work alongside the respiratory therapist to verify ventilator settings, such as mode, tidal volume, FiO2, and PEP, ensuring they align with the prescribed treatment plan. Regular discussions about the patient's oxygenation status, compliance, and any signs of distress, e.g., desaturation asynchrony, help us make timely adjustments. For example, if the patient exhibits increased peak pressures, we might collaborate to check for tube obstruction or consider a recruitment maneuver. Additionally, I would maintain open communication with the physician or intensivist, providing updates on the patient's response to ventilation, ABG results, and sedation needs. If the patient is being weaned, I would participate in daily rounds to discuss readiness for spontaneous breathing trials or potential extubation. Meanwhile, partnering with pharmacists ensures proper sedation and analgesia to minimize ventilator-induced discomfort while avoiding oversedation. Beyond clinical adjustments, I would engage with physiotherapists to implement lung protective positioning, e.g., prone ventilation for ARDS, and mobilize the patient when feasible. Nutritionists also play a key role in optimizing caloric intake to support respiratory muscle strength. Finally, I would involve infection control specialists to mitigate risks like VAP through strict adherence to hygiene protocols and oral care. By fostering a team-based approach, I ensure that all interventions, from ventilator management to holistic care, are integrated seamlessly, prioritizing the patient's stability and recovery.
Can you share an experience where you received feedback on your ventilator handling? How did you respond?
I recall a specific instance early in my intensive care unit career where I received crucial feedback regarding my ventilator handling, and it profoundly impacted my approach to patient care. I was looking after a patient recovering from a severe acute respiratory distress syndrome, who was on a volume-controlled ventilation mode. While numerically, all the ventilator parameters seemed within the prescribed ranges, I noticed a subtle, persistent restlessness in the patient. His breathing efforts, though present, struck me as somewhat strained, which I initially attributed to general anxiety or perhaps mild discomfort. During her rounds, my charge nurse, a highly experienced critical care nurse with extensive knowledge in respiratory physiology, observed the patient for a few moments. She then quietly approached the ventilator and pointed to the flow time waveform on the screen. She gently asked me, "Andrew, can you tell me what you interpret from this flow pattern, especially at the end of inspiration?" I admitted that while I understood the basic concept of flow waveforms, I hadn't given this specific detail enough attention, as the pressure and volume loops appeared satisfactory. She then patiently explained that the flow waveform indicated a premature termination of inspiratory flow, meaning the ventilator wasn't delivering air quickly enough to meet the patient's inspiratory demand. This phenomenon, known as flow starvation, was causing his subtle agitation and increased work of breathing, despite the delivered tidal volume being correct. Her feedback was incredibly insightful and delivered in a supportive, educational manner. She then demonstrated how to adjust the inspiratory flow rate on the ventilator, allowing for a more natural, patient-driven flow delivery. Almost immediately, I observed a remarkable change in the patient. His restlessness subsided, his breathing became visibly smoother, and he appeared much more comfortable and synchronous with the ventilator. My response was one of immediate recognition and sincere gratitude. I thanked her profusely for her astute observation and clear explanation, acknowledging the critical insight she had provided. Following this experience, I made it a point to integrate comprehensive waveform analysis into my routine ventilator assessments. I dedicated specific time during every shift to thoroughly review all ventilator graphics, understanding the nuances of flow, pressure, and volume curves, and always correlating them with a patient's clinical presentation. I also actively sought out further education on patient ventilator asynchrony and frequently consulted with our respiratory therapist to deepen my understanding. This experience was a pivotal learning moment, transforming my understanding of ventilator management from merely setting parameters to truly optimizing patient-ventilator interaction. It underscored the invaluable role of experienced mentorship and continuous learning in refining clinical judgment in critical care.
How would you handle a situation where a fellow staff member is not following ventilator protocols?
Facing a situation where a fellow staff member is not following ventilator protocols requires a professional, constructive, and immediate approach, prioritizing patient safety above all else. My initial response would depend on the perceived urgency and potential for patient harm. If I observe a protocol deviation that poses an immediate risk to patient safety, for instance, improper suctioning technique, unaddressed alarms, or incorrect setting adjustments, my first action would be to intervene directly and calmly to correct the immediate issue. This might involve gently reminding them of the correct procedure, offering to assist, or even physically taking over the task if the patient's condition demands it. My focus in that moment is solely on ensuring the patient is safe and receives appropriate care. For example, if I see someone performing an open suctioning without proper sterile technique, I would immediately and politely say, just a quick reminder, we need to ensure sterile gloves for this procedure to prevent infection, and guide them to the correct supplies. Once the immediate patient safety concern is addressed, or if the deviation is less urgent but still critical, e.g., consistently missing hourly ventilator checks, I would then choose an appropriate time and place for a private, non-confrontational conversation with a colleague. I would approach them away from the patient's bedside, perhaps in the break room or a quiet office, to discuss the observation. My tone would be supportive and collaborative, not accusatory. I would start by stating my observation factually. For example, I noticed earlier that the ventilator circuit check wasn't documented, or the oral care for Mr. Johnson on the ventilator wasn't done at the usual time. Following that, I would gently explain the rationale behind the protocol, highlighting the potential patient safety implications. For instance, those hourly checks are vital for early detection of leaks or disconnections, which could compromise his ventilation, or consistent oral care is crucial to prevent ventilator-associated pneumonia. I would then offer my support, asking if they are facing any challenges, feel overwhelmed, or require a refresher on the protocol. It's possible they are new, stressed, or simply overlooked something. This approach opens a dialogue rather than creating defensiveness. If after this direct but gentle approach, the noncompliance persists, or if the issue is a recurring pattern with multiple staff members, I would then escalate the concern through the appropriate chain of command. This would typically involve discussing the issue with a charge nurse, team leader, or nurse manager. When escalating, I would focus on the facts, the observed deviations, the potential risks to patients, and the steps I've already taken to address it. My aim would be to seek support in reinforcing the protocol across the team and ensure consistent, safe practices are maintained for all patients on mechanical ventilation. My ultimate responsibility is to advocate for patient safety, and ensuring adherence to established protocols is a key part of that.
If two team members disagree on the appropriate ventilator mode for a patient, how would you facilitate a resolution?
When two team members disagree on the appropriate ventilator mode for a patient, my primary objective would be to facilitate a resolution that prioritizes optimal patient care and safety, grounded in evidence-based practice. My approach would be structured and collaborative. Firstly, I would ensure the patient's immediate safety and stability by confirming that the current ventilator settings, regardless of the preferred mode, are not causing immediate harm and are providing adequate ventilation and oxygenation. This buys us time to resolve the disagreement systematically. Next, I would facilitate a calm and professional discussion between the two team members, ideally at the bedside or in a private area if feasible, to avoid escalating the tension or disturbing the patient. I would encourage both individuals to clearly articulate their reasoning for advocating a particular mode, drawing upon their clinical assessment findings, the patient's current condition, and relevant evidence. For instance, one might argue for a volume-controlled mode due to concerns about maintaining minute ventilation, while the other might prefer a pressure-controlled mode to optimize lung protection based on compliance. I would actively listen to both perspectives, ensuring each individual feels heard and understood. During this discussion, my role would be to bring the focus back to the patient's specific needs and goals of care. We would consider factors such as the underlying pathology, e.g. ARDS, COPD exacerbation, the patient's spontaneous breathing efforts, their hemodynamic stability, and the overall goals for ventilation, e.g., lung protection, weaning, minimizing work of breathing. I would ask clarifying questions to help them consider all angles and potentially identify common ground or areas of misunderstanding. If the disagreement persists despite a thorough discussion of the patient's needs and evidence, I would then suggest escalating the discussion to a more senior or specialized team member. This would typically involve bringing in the attending physician, a critical care intensivist, or a senior respiratory therapist. This provides an unbiased, expert third party to weigh the arguments, review the patient's data, and make an informed decision based on their broader experience and the latest clinical guidelines. This escalation is not about placing blame, but about leveraging collective expertise for the best patient outcome. Finally, once a decision is made, I would ensure that all team members understand the rationale behind the chosen ventilator mode and that the care plan is clearly documented and communicated. This fosters a cohesive approach to patient care and ensures that future management aligns with the agreed-upon strategy. My goal in such a situation is to promote effective communication, uphold patient safety, and reinforce a culture of collaboration and evidence-based decision-making within the team.
During a field emergency, how would you assess and treat a patient who requires immediate ventilation support?
In a field emergency where a patient requires immediate ventilation support, my approach would be guided by the universally recognized principles of immediate assessment and rapid intervention, adhering to the ABCs, airway, breathing, circulation of emergency care, while prioritizing patient safety and initiating transport to definitive care. My very first step would be to ensure scene safety for myself and the patient, then perform a quick primary assessment to identify life-threatening conditions. This involves rapidly checking for responsiveness, assessing the airway for patency, looking for obstructions, foreign bodies, or facial trauma, and immediately assessing breathing. If the patient is unresponsive, has absent or agonal breathing, or is severely hypoventilating, I would instantly recognize the need for immediate ventilation support. Once the need for ventilation is established, my next priority is to open and maintain the airway. This would involve using head tilt chin lift or jaw thrust maneuvers, and if necessary, inserting an oropharyngeal airway, OPA, or nasopharyngeal airway, NPA, to ensure the tongue does not obstruct the airway. Simultaneously, I would prepare for positive pressure ventilation. For ventilation support, I would immediately begin manual ventilation using a bag valve mask, BVM, device attached to 100% supplemental oxygen. It is critical to ensure a good mask seal over the patient's face and to deliver breaths at an appropriate rate, typically 10 to 12 breaths per minute for adults, observing visible chest rise and volume. While ventilating, I would continuously monitor for chest rise and fall, and if available, utilize pulse oximetry to monitor oxygen saturation, aiming for SpO2 above 94%. Concurrently with ventilation, I would swiftly move to assess circulation, checking for a pulse and managing any life-threatening hemorrhage. If no pulse is present, I would immediately initiate high-quality chest compressions and follow basic life support, BLS, or advanced cardiovascular life support, ACLS protocols as appropriate, integrating ventilation with compressions. During these initial critical interventions, I would also be conducting a rapid secondary assessment to identify the potential cause of the respiratory failure and any other injuries. This involves a quick head-to-toe survey, looking for signs of trauma, overdose, anaphylaxis, or other medical emergencies. Gathering a brief history from bystanders or family, if available, regarding the onset of symptoms or any pre-existing conditions would be helpful. Throughout this process, communication is key. I would clearly articulate the patient's condition and the interventions being performed to any arriving emergency medical services, EMS personnel, or other healthcare providers. My ultimate goal in the field is to stabilize the patient's breathing and oxygenation to the best of my ability with the available resources, and then rapidly prepare them for safe and expedited transport to a definitive care facility where advanced airway management, diagnostic tests, and comprehensive treatment can be provided. The focus is always on buying time for the patient until they reach a higher level of care.
Suppose you are facing a shortage of ventilators during a surge. How would you prioritize their usage?
In a field emergency where a patient requires immediate ventilation support, my approach would be guided by the universally recognized principles of immediate assessment and rapid intervention, adhering to the ABCs, airway, breathing, circulation of emergency care, while prioritizing patient safety and initiating transport to definitive care. My very first step would be to ensure scene safety for myself and the patient, then perform a quick primary assessment to identify life-threatening conditions. This involves rapidly checking for responsiveness, assessing the airway for patency, looking for obstructions, foreign bodies, or facial trauma, and immediately assessing breathing. If the patient is unresponsive, has absent or agonal breathing, or is severely hypoventilating, I would instantly recognize the need for immediate ventilation support. Once the need for ventilation is established, my next priority is to open and maintain the airway. This would involve using head tilt chin lift or jaw thrust maneuvers, and if necessary, inserting an oropharyngeal airway, OPA, or nasopharyngeal airway, NPA, to ensure the tongue does not obstruct the airway. Simultaneously, I would prepare for positive pressure ventilation. For ventilation support, I would immediately begin manual ventilation using a bag valve mask, BVM, device attached to 100% supplemental oxygen. It is critical to ensure a good mask seal over the patient's face and to deliver breaths at an appropriate rate, typically 10 to 12 breaths per minute for adults, observing visible chest rise and volume. While ventilating, I would continuously monitor for chest rise and fall, and if available, utilize pulse oximetry to monitor oxygen saturation, aiming for SpO2 above 94%. Concurrently with ventilation, I would swiftly move to assess circulation, checking for a pulse and managing any life-threatening hemorrhage. If no pulse is present, I would immediately initiate high-quality chest compressions and follow basic life support, BLS, or advanced cardiovascular life support, ACLS protocols as appropriate, integrating ventilation with compressions. During these initial critical interventions, I would also be conducting a rapid secondary assessment to identify the potential cause of the respiratory failure and any other injuries. This involves a quick head-to-toe survey, looking for signs of trauma, overdose, anaphylaxis, or other medical emergencies. Gathering a brief history from bystanders or family, if available, regarding the onset of symptoms or any pre-existing conditions would be helpful. Throughout this process, communication is key. I would clearly articulate the patient's condition and the interventions being performed to any arriving emergency medical services, EMS personnel, or other healthcare providers. My ultimate goal in the field is to stabilize the patient's breathing and oxygenation to the best of my ability with the available resources, and then rapidly prepare them for safe and expedited transport to a definitive care facility where advanced airway management, diagnostic tests, and comprehensive treatment can be provided. The focus is always on buying time for the patient until they reach a higher level of care.
How do you keep yourself updated with the latest developments in ventilator technology?
Keeping abreast of the latest developments in ventilator technology is essential for providing optimal and safe patient care, particularly in critical care environments. I employ a multifaceted approach to ensure my knowledge and skills remain current. Firstly, continuous professional development, CPD activities are a cornerstone of my strategy. I regularly attend specialized workshops, seminars, and webinars focused on mechanical ventilation, often offered by professional nursing organizations, critical care societies, or even ventilator manufacturers. These events often highlight new modes, advanced monitoring capabilities, and best practices for specific patient populations. For example, a recent webinar I attended focused on the implementation of adaptive support ventilation and the integration of artificial intelligence in ventilator algorithms, which has provided me with valuable insights into personalized patient care. Secondly, I make it a point to engage with professional literature and evidence-based guidelines. I subscribe to and regularly read leading critical care nursing journals and respiratory therapy publications. These journals often publish research on new ventilator technologies, outcomes of different ventilation strategies, and updated clinical guidelines. I also routinely access resources from reputable organizations such as the American Association of Critical Care Nurses, AACN, or the European Society of Intensive Care Medicine, ESICM, which frequently release updated recommendations and best practice bundles related to ventilator management and prevention of ventilator-associated complications. Thirdly, interdisciplinary collaboration plays a crucial role. I actively engage with respiratory therapists and critical care physicians in my unit. These colleagues are often at the forefront of implementing new technologies and strategies. Participating in daily rounds, asking questions about ventilator changes, and discussing patient responses to new settings allows for real-time learning and knowledge exchange. For instance, when a new type of non-invasive ventilator was introduced in our unit, I made sure to receive hands-on training from our respiratory therapists and understood its unique features and applications. Fourthly, I leverage online educational platforms and manufacturer resources. Many ventilator manufacturers provide online training modules, user manuals, and technical specifications for their latest models. Reviewing these resources helps me understand the nuances of specific devices and their advanced functionalities. Online nursing education platforms also offer courses specifically designed to update nurses on emerging trends in mechanical ventilation. Finally, I believe in sharing knowledge and learning from experience. When new technology or a complex case involving advanced ventilation arises, I actively participate in post-case debriefs and discussions within the team. I also seek opportunities to precept junior nurses, as explaining concepts to others often solidifies my own understanding and encourages me to review foundational and advanced topics. This combination of formal education, continuous reading, active collaboration, and experiential learning ensures I remain proficient and up-to-date with the evolving landscape of ventilator technology.
Share an experience where you had to adapt quickly to changes in ventilator technology or procedures. What was the outcome?
A particularly memorable experience where I had to adapt quickly to a significant change in ventilator technology occurred about 2 years ago, when our intensive care unit transitioned to a new generation of mechanical ventilators. Our previous models were reliable, but featured a more traditional, knob-based interface. The new ventilators, however, were equipped with a highly advanced touchscreen interface, numerous new graphical displays, and integrated software for advanced lung mechanics calculations and automated weaning protocols. Initially, this felt like a steep learning curve. While we had received some brief in-service training sessions, the real challenge came on the first shift when a patient needing complex ventilation was admitted, and I was assigned to their care using one of the new machines. The patient had severe ARDS, necessitating meticulous lung protective ventilation strategies and frequent adjustments. My immediate response was to prioritize patient safety while actively engaging with the new technology. I meticulously reviewed the patient's prescribed settings against the ventilator's display, cross-referencing with the physician's orders. When faced with the new graphical displays, which I wasn't yet fully proficient in interpreting, I immediately sought assistance from the respiratory therapist who was also at the bedside. I openly communicated my unfamiliarity with some of the advanced features, stating, "This new interface is quite different. Could you walk me through interpreting these specific waveforms for this patient's condition?" The respiratory therapist was incredibly helpful. Instead of feeling overwhelmed, I focused on active learning in real time. As she explained the new display for auto PEEP or compliance curves, I would physically trace the changes on the screen, asking clarifying questions. I made quick notes on key navigation pathways and new alarm interpretations directly at the bedside. During less critical moments on the shift, I utilized the ventilator's test lung function to practice adjusting settings and observing the new graphic responses in a low-stakes environment, solidifying my understanding of the interface. The outcome was positive. Despite the initial challenge, I was able to safely and effectively manage the patient's ventilation throughout my shift. By proactively seeking immediate expert guidance and engaging in hands-on practice, I quickly gained a foundational understanding of the new ventilator's operation. Within a few shifts, my confidence grew significantly, and I became proficient in utilizing the advanced features, which ultimately improved my ability to fine-tune ventilation for better patient synchrony and lung protection. This experience reinforced the importance of continuous learning, open communication, and quick adaptation in a rapidly evolving technological landscape within critical care.
If you were asked to implement a new type of ventilator in your ward, how would you approach the training of staff?
If tasked with implementing a new type of ventilator in our ward, my approach to staff training would be comprehensive, phased, and highly collaborative, ensuring that all nurses develop both confidence and competence before the new equipment is fully integrated into routine patient care. My ultimate goal would be to minimize disruption to patient care and maximize staff adoption and proficiency. Initially, I would begin with a thorough needs assessment to understand the current skill set of the nursing staff regarding mechanical ventilation in general and their familiarity with similar technologies. This would help tailor the training content. Concurrently, I would collaborate closely with the ventilator manufacturer's clinical educators to secure their expertise and resources, as they are best equipped to provide detailed instruction on the new device's specific features, functionalities, and advanced capabilities. I would also work with our unit's respiratory therapists and biomedical engineers, as they are key partners in ventilator management and technical support. The training itself would be structured in multiple phases. The first phase would involve didactic sessions, perhaps a mix of in-person presentations and online modules, focusing on the theoretical aspects of the new ventilator. This would cover its unique modes of ventilation, alarm systems, safety features, and the interpretation of its advanced graphical displays. This initial phase would lay the conceptual groundwork. Following the theoretical component, the critical second phase would be hands-on practical training. This is paramount for building competence. We would set up dedicated training stations within the ward, utilizing demo ventilators and test lungs. Nurses would rotate through these stations, practicing initial setup, troubleshooting common alarms, performing circuit changes, and familiarizing themselves with all the buttons and touchscreen navigations. This would be facilitated by the manufacturer's representatives and our own expert respiratory therapists. I would emphasize a train-the-trainer model, identifying and empowering key nurses from each shift to become super users who can then mentor their colleagues. The third phase would involve simulated scenarios. We would run realistic patient scenarios using high-fidelity mannequins, allowing nurses to practice managing complex situations, such as sudden desaturations or ventilator malfunctions, on the new device in a safe, controlled environment. This builds critical thinking and quick decision-making skills. Throughout all practical phases, competency checklists will be utilized to ensure each nurse demonstrates proficiency in all essential functions before being cleared to use the new ventilator with patients. Finally, during the initial weeks of implementation, I would ensure enhanced bedside support. This means having respiratory therapists or designated super users available on each shift to provide immediate guidance and troubleshooting assistance to nurses as they use the new ventilators with actual patients. Regular debriefings and feedback sessions will be scheduled to address any challenges, share best practices, and refine protocols as needed. My goal is to create a supportive learning environment that empowers nurses to confidently and competently utilize the new technology, ultimately enhancing patient safety and care quality.
Tell me about a time when you had to give directions or train a team member on the use of ventilators. How did you approach this?
In my previous role, I frequently found myself in situations where I needed to orient new team members, particularly new graduate nurses or nurses transferring from different specialties, to the intricacies of ventilator use on our critical care unit. One specific instance comes to mind where I had to train a new colleague, Sarah, on initiating mechanical ventilation and navigating the specific functions of our unit's primary ventilator model, an advanced system with numerous modes and complex graphics. My approach was multifaceted, focusing on patient safety, practical application, and building Sarah's confidence. I started by understanding Sarah's baseline knowledge. I asked her about her previous exposure to ventilators and her comfort level with different modes. This helped me tailor my teaching to her specific needs, avoiding redundancy while ensuring foundational concepts were solid. Next, I broke down the training into manageable, logical steps, starting with the most critical aspects. We began by reviewing the pre-use safety checks. I physically walked her through each step of the ventilator's self-test, explaining the importance of the leak test and alarm verification. I emphasized why each step was crucial for patient safety, linking it back to potential adverse outcomes if overlooked. For example, I demonstrated how a small circuit leak, if unnoticed, could lead to inaccurate tidal volume delivery and inadequate ventilation. Once the safety checks were clear, we moved to initiating ventilation. I used a test lung connected to the ventilator, allowing Sarah to practice setting up a basic mode like volume control, VC, and observing the corresponding waveforms and numerical data without patient risk. I guided her through adjusting tidal volume, respiratory rate, PEEP, and FiO2, explaining the physiological impact of each adjustment. I encourage her to manipulate the settings and observe the immediate changes on the screen, fostering an experiential learning approach. A significant part of the training focused on alarm management. This is often an area of anxiety for new staff. I intentionally triggered various alarms, e.g., high peak pressure, low minute ventilation apnea, on the test lung, guiding Sarah through the steps to identify the cause and effectively resolve each one. I taught her the systematic approach to troubleshooting, emphasizing patient assessment as the first and foremost step before engaging with a machine. Throughout the training, I maintained an open and supportive environment, encouraging Sarah to ask questions, no matter how basic they seemed. I offered immediate, constructive feedback, praising her correct actions and gently correcting any errors, always explaining the rationale. I also shared practical tips and tricks I had learned over time, such as correlating ventilator alarms with patient presentation. The outcome was very positive. Within a few shifts, Sarah demonstrated a strong grasp of the ventilator's operation and alarm management. She became confident in initiating ventilation, making routine adjustments, and responding effectively to alarms. This systematic, hands-on, and supportive training approach not only ensured her competence but also significantly boosted her confidence, making her a valuable and safe team member in managing mechanically ventilated patients.
Describe a situation where you had to work closely with others in a high-pressure environment. How did you manage the relationships?
One situation that immediately comes to mind where I had to work very closely with others in a high-pressure environment was during a massive trauma influx following a multi-vehicle collision on a busy highway near our hospital. The emergency department quickly became overwhelmed, and our critical care unit was designated to receive the most severely injured patients, many of whom required immediate resuscitation and mechanical ventilation. The pressure was immense. We had multiple critically unstable patients arriving simultaneously, each requiring rapid assessment, interventions, and continuous monitoring. The team consisted of myself, another ICU nurse, 2 resident doctors, an attending intensivist, and a respiratory therapist, all working in a relatively confined space. The sheer volume of tasks, the severity of the injuries, and the constant flow of information and orders created an intensely stressful atmosphere. My approach to managing relationships in this high-pressure scenario focused on clear, concise communication and a strong emphasis on role clarity and mutual support. Firstly, I made it a point to use closed-loop communication for all critical information and orders. For example, when the doctor ordered a medication, I would repeat the drug, dose, and route back to them, then verbally confirm administration. This prevented misunderstandings and ensured accuracy in a chaotic environment. Similarly, when relaying patient assessments or ventilator changes to the respiratory therapist, I kept my updates succinct and focused on pertinent data. Secondly, I actively sought to reinforce role clarity and trust. Everyone knew their primary responsibilities. My focus was on the patient's immediate nursing needs, ventilator management, and medication administration. However, I also made sure to anticipate the needs of my colleagues. For instance, while the resident was inserting a central line, I would proactively prepare the necessary equipment or adjust ventilator settings if needed, without being asked. This anticipation and willingness to assist wherever possible built trust and efficiency. I noticed moments where the respiratory therapist was juggling multiple alarms, and I would offer to check on a less critical alarm while they focused on the priority. Thirdly, I actively managed my own stress response to remain a calm presence for the team. This involved taking brief, intentional deep breaths before escalating a concern or performing a critical task. My composure, even under pressure, helped to maintain a sense of calm and control within our immediate patient care area, preventing the stress from becoming contagious. Finally, at appropriate moments, I made an effort to offer brief words of encouragement or acknowledgement to my colleagues, even just a quick "good job with that intubation, doctor," or a "thanks for catching that, Paul." These small gestures of recognition, even amidst the chaos, fostered a sense of camaraderie and reminded us that we were a cohesive unit tackling a formidable challenge. The outcome was that despite the extreme pressure and the critical nature of the patients, our team functioned incredibly effectively. We managed to stabilize all the patients and successfully transfer them to appropriate beds within the ICU. The ability to communicate clearly, trust in each other's competencies, and provide proactive support was fundamental to our success, allowing us to deliver high-quality care even in the most demanding circumstances. This experience truly highlighted the power of effective teamwork when stakes are at their highest.